Basic principles of eyelid reconstruction. What are the aims? To protect the ocular surface with mucosa on the inner lining, adequate length to cover the cornea, must be mobile to clear the visual axis, spread the tear film over the cornea, stable margin to prevent abrasion of cornea, acceptable cosmetic appearance. Indications for eyelid reconstructions can be congenital anomalies or acquired defects, which may be post-traumatic infection, post-surgical defects due to malignancy excision, plus cosmetic improvement. Basic components of eyelid: anterior lamella, skin and orbicularis oculi. Posterior lamella consists of tarsus and conjunctiva. Canthal tendons, upper and lower canaliculus, levator complex. Method of reconstruction depends upon the size of the defect both in the horizontal and vertical directions, cause of the defect, availability and condition of periocular tissue, age and lifestyle, monocular or binocular vision, general condition of the patient. Size of the defect can be small if it is less than 20% of the length, moderate if it is 40 to 50%, large if it is more than 50%. A complex eyelid defect may be defined as one that involves more than 50% of a cosmetic unit along with loss of components of the lid and periorbital area. Periorbital defects often present a surgical challenge because of the need to provide ocular protection. Lacrimal drainage system patency, eyelid function and aesthetics. Periorbital defects are classified as any defects involving the medial or lateral canthus, upper or lower eyelid or the brow. Complex eyelid defects would have full thickness loss. Hence, for reconstruction, for both anterior and posterior lamella will have to be provided. They should be replaced by like for like tissue. One has to be well vascularized to support the second lamella. In the reconstruction ladle, we start with heal by secondary intention, direct closure, skin graft, local flap, distant flap, or free flap. Basic guidelines are: one by vascularized tissue, one can be graft, canthal fixation must be done, narrow the defect, Choose the method according to quality and laxity of skin, availability of tissue, size and site of defect, lifestyle of the individual. Cover or anterior lamella. It can be split skin graft or full thickness skin graft or flaps. For posterior lamella, the available tissues are conjunctiva, mucous membrane, nasal mucosa, palatal mucoperiosteum, ear cartilage with perichondrium, banked sclera, preputial or labia majora tissue. Case of a congenital coloboma. Congenital coloboma of upper eyelid is defined as a notch or gap in the eyelid. It indicates incomplete closure of the embryonic fissure. Coloboma of lower eyelid is associated with craniofacial cleft. Here you see a case of a coloboma of upper eyelid, a simple coloboma, or a complex coloboma which is associated with cryptophthalmos or associated with golden heart syndrome. Simple coloboma. Basic guidelines are a pentagon incision, marginal suturing, conjunctival suturing which should be buried, lateral cantholysis if there is tension. Initially there will be ptosis, subsequently it gets cleared. It is better to do it in a neonate also. Bilateral cryptophthalmos producing congenital symblephrone. On the left side, upper eyelid is reconstructed using advancement tarsoconjunctival flap. On the right side, Mustardase lid switch is done. A follow-up 18 months later shows the defect well covered. Golden heart syndrome, epibulbar dermoid, anterior lamella shortening, lateral canthal defect, lateral cleft lip, hemifacial microsomia, lateral canthal reconstruction, anterior lamellar correction with FTSG, epibulbar dermoid removal. Tumors of eyelid. They can be benign lesions or malignant lesions. Benign lesions like inflammatory, chalazion, warts, nevus, hemangioma, neurofibromatosis, deposition disorder, xanthelasma palpebrum, amyloidosis, malignant lesions like basal cell carcinoma, squamous cell carcinoma, sebaceous gland carcinoma, malignant melanoma, or Merkel cell carcinoma. Eyelid tumors can be marginal or extramarginal. The extramarginal may only involve the skin or only the conjunctiva or the entire lid thickness, as in a complex tumor is described. Treatment: primary and immediate reconstruction is advised. Incision biopsy, tumor excision under frozen section, or Mohs microsurgical excision. Reconstruction of lower eyelid defect can be extramarginal. Only skin loss depending on the size, which can allow primary closure, or full thickness skin graft, local flap, or flap from nearby area. Reconstruction of lower eyelid smaller defect. Marginal can do a direct closure or direct closure with cantholysis, direct closure with a semicircular flap. Reconstruction of lower eyelid larger defects. Posterior lamella by tarsoconjunctival flap from upper eyelid, called as the Hughes flap, or MMG can be placed. Anterior lamella with split skin graft or full thickness skin graft, or advancement flap from cheek. Mustardase cheek rotation flap can be used. Trippier flap with graft for posterior lamella, median forehead flap, or nasolabial flap. Hughes tarsoconjunctival flap, which was described in 1937. Upper lid split at the mucocutaneous junction and posterior lamella dissected. Dissection carried between levator complex and Muller's muscle and subcutaneous tissue. Tarsoconjunctival flap sutured to the lower lid defect. Anterior lamella from advancement of the cheek skin. Hughes tarsoconjunctival flap. Second stage at 4 weeks was required for free transplantation of the upper lid eyelashes. And a third stage after an additional 12 weeks was required for division and inset of the flap. Hughes also described a reversed Hughes flap for the repair of upper lid with the lower lid as the donor. In 1981, McCord and Nunnery described modified Hughes flap. They recommended that inferior edge of the Hughes flap must be at least 4 millimeters away from the lid margin for sufficient tarsal plate to remain in the upper eyelid to prevent postoperative deformity. The best plane of dissection for the Hughes flap is between Muller's muscle and the levator aponeurosis. Here you see a case of a pigmented basal cell carcinoma of the lower eyelid, which was reconstructed using a Hughes tarsoconjunctival flap and cover from the upper eyelid skin. Sebaceous gland carcinoma, nodular variety, tarsoconjunctival flap to be raised 4 millimeters from the lid margin, dissection between Muller's muscle and LPS. Some retraction of upper lid is expected. Anterior lamella by advancement from cheek if lax tissue is available. Excise Burroughs triangle to get more advancement. Full thickness skin graft can also be used. Aesthetic unit has to be kept in mind. Complex eyelid reconstruction, a case of a basal cell carcinoma which was excised. For the lower eyelid reconstruction, Hughes tarsoconjunctival flap was used and the raw area was covered with split skin graft. Lower eyelid reconstruction using a Mustardase cheek rotation flap. A basal cell carcinoma excised. Lining was provided with a palatal graft. For the cover, cheek rotation advancement flap was utilized. The rotation should rise higher. Lateral support of canthus to the periosteum must be provided. Trippier described in 1889 a musculocutaneous flap in the form of a bridge applied in the reconstruction of eyelids. This is the first description of musculocutaneous flap. Conclusion of Trippier article. The musculocutaneous flap in the form of a bridge applied to the restoration of eyelids renders them form and movement at the same time. With the aid of this flap taken on the upper eyelid, one can completely reconstruct the lower eyelid. In taking an analogous flap from immediately above the eyebrow, one can reconstruct certain defects of a half or even 2/3 of the upper eyelid. The three variations of Trippier flap as described by Brito in 2004. The first variation remains in use as a means of lower eyelid reconstruction and is still commonly called Trippier flap. The second variation is a musculocutaneous flap based on the prefrontal orbicularis oculi fibers from above the eyebrow for reconstruction of upper eyelid. It's no longer used. It has been used for marginal and extramarginal loss of lower eyelid, especially the central and horizontal defects. As the flap is taken from the upper eyelid, it can be used only if skin is lax, otherwise a skin graft would be needed. The height of the flap is the limitation of this method. It has a tendency to tube itself. To avoid this, it has to be lined with chondromucosal graft from the nasal septum. It can be made unipedicle or medial and lateral. Here you see a 35-year-old lady with a bullet injury. There was loss of left eye and lower eyelid. No lower eyelid and inferior fornix to retain the processes. Large adherent scar below the lower eyelid. Both anterior and posterior lamella required. Posterior lamella, tarsoconjunctival flap from upper eyelid, lid margin by trippier flap from upper eyelid, excision of scar over cheek, resurfacing with FTSG, custom made prosthetic eye shell has been given. Trippier bridge flap, height of 8 to 12 millimeter depends on laxity of skin of upper eyelid. Donor area can be grafted. Medial and lateral pedicle can be used for margin or below margin. Chondromucosal graft to prevent tubing of the flap. Towards cosmesis. It's been reconstructed with a trippier flap and skin graft. As there was depression, autologous fat graft was used, and one can see the improvement in this position. The third variation of trippier flap, as described by Brito. The third variation is a bucket handle flap designed immediately below the eyebrow on the upper preseptal fibers of orbicularis oculi. The flap is similar to the first flap of trippier, but uses the tissues higher and closer to the lower margin of eyebrow. The flap is passed over the skin, covering the tarsal plate to reconstruct the upper eyelid margin defect. The donor site is reconstructed with FTSG. Here is a video of a defect in the upper eyelid. A a mucoperiosteal flap was used to form the inner lining. Incision made below the eyebrow and keeping the medial and lateral pedicle intact. The skin along with orbicularis is raised and shifted down to cover the tarsal plate. On the raw area, full thickness skin graft is placed. Now, reconstruction of upper eyelid. Extramarginal, loss of only the anterior lamella. Split skin graft, full thickness skin graft or local flap can be used. Here you see a small tumor in the upper eyelid which was excised and the defect closed directly. Post-chemical injury, ectropion of the upper eyelid, release and FTSG done for both the sides. The grafted area was treated to silicone gel sheet, and as days passed by, the hypertrophic margins all settled down. Reconstruction of upper eyelid larger defect, Cutler beard method, in which tarsoconjunctival flap from lower eyelid is transferred. The anterior lamella is covered with split skin graft or full thickness skin graft, or advancement flap from the lower eyelid. Mustardase lid switch from lower eyelid can be used. Forehead flap from the temporal side or median forehead flap can be used. Here you see the posterior lamellar reconstruction of the upper eyelid using a tarsoconjunctival flap. Free graft of mucosa was used, which you can see covering the cornea. Mustardase lid switch for the upper eyelid. The flap is raised. Flap is turned onto the defect and donor area is sutured first. Flap is inserted into the defect in 2 layers. Here you see the flap has been attached. For a larger defect, especially the sebaceous gland carcinoma, a tarsoconjunctival flap is used, and advancement flap from the lower lid and cheek is advanced over the defect to cover. After division, the reconstruction is complete. Larger defect, the same method of using the cheek skin to cover the anterior lamella. Anterior lamellar reconstruction using a temporal forehead flap. The flap is designed, harvested above the eyebrow. It's used for defects of the upper as well as lower eyelid. It's usually temporally placed. Defect of the lateral canthus also can be used. A pagetoid spread due to the sebaceous gland, which was excised completely and reconstructed using the fricase flap for the cover. A post-traumatic case in which there was a lot of scarring of the lower eyelid, which was released, and a fricae flap was used to cover the lower eyelid scarred area and the lateral canthal area too. Once that has been done, this is the only seeing eye. Patient has had a corneal transplant and it has done well. Complex eyelid reconstruction. Again, the defect covered by mucous membrane graft over which a median forehead flap was used to cover. A complex eyelid defect. For the lower eyelid defect, a nasolabial flap was raised and transferred. It gives a good result. Patient is using a prosthetic eye. Here you can see the anterior lamella as well as nasolabial flap being used. There was depression in the temporal area for which autologous fat graft was placed in. Same patient, different views to show the scar revision. Patient, when we took the fricase flap, it gave rise to a good broplasty, and the customized eye shell gave a good contour. Rare craniofacial cleft, Tessier 4 bilateral. Both the coloboma of the lower eyelid were corrected and reconstructed using nasolabial flap on both the sides. For the medial canthal defects, partial skin graft can be placed or full thickness skin graft. A glabular transposition flap can be utilized. Median forehead flap. Laissez-faire defect is allowed to heal by granulation. Here you see a basal cell carcinoma in the medial canthus extending onto the lower eyelid, excised, and a median forehead flap was raised and utilized to cover the defect produced after excising the basal cell carcinoma. Complex eyelid reconstruction using a medial forehead flap which covered the lower eyelid and the medial canthal area. Post-traumatic case. A full thickness skin graft in a kissing nevus. The tarsoconjunctival flaps from both the lids were advanced and a tarsorrhaphy was done. Full thickness skin graft from the arm was utilized to cover the upper eyelid and the lower eyelid. Patient had a loss of both the eyelids. There was a total ankyloblepharon. Reconstruction done. For the upper eyelid, fricae flap and MMG was placed. Subsequently, for the lower eyelid, nasolabial flap with palatal graft was utilized. Globe was retained, but over it an CMP was placed. A case like this has had a free flap done to correct the contracted socket. This is a challenge. Many of the fundamental techniques in oculoplastic surgery have evolved from sources known and unknown over the years. These techniques have been further refined with better knowledge of anatomy and physiology, besides improvement in instrumentation. Thank you.